Symptomology for schizophrenia is as follows. 2 or more during the 1 month period. Delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms, meaning diminished emotions, negative affect, etc. There also must be a significant disturbance in level of functioning, whether it be work, school, or any other sphere in that person's life. Continuous signs of disturbance persist for at least 6 months. So you have to make sure that it's not just because of something else, that it's because there's something wrong with their brain. And you have to rule out schizoaffective or depressive bipolar. Those need to be ruled out because there's great overlap in those two, but they're treated completely differently. And a big indicator is there's no major manic or depressive episodes present. And if there aren't, then they probably have schizophrenia. And it cannot be attributable to a substance. So the person who's taking it must be clean of substances, and the hallucinations cannot be because of substances. And the thing with schizophrenia is it's heterogeneous, meaning it's different for every single person. So symptoms that may occur in one person may be different in another. So it's a constellation of signs and symptoms that need to be addressed and seen. So if someone's just having delusions, they might not have schizophrenia necessarily. They have to have a constellation of symptoms in order to be fully diagnosed with schizophrenia. Some ethical considerations to be aware of when dealing with schizophrenic patients is telling half-truths to patients who are paranoid. Because they're paranoid, they may not believe that they need medication. So, telling them that their medication will ease their anxiety because of the delusional symptoms, so it's kind of a half-truth. You're not telling them that they're going to be on antipsychotics, but you're not telling them that, they're crazy either. So, telling half-truths to patients who are paranoid is a big ethical consideration to determine whether or not you're going to do it. And another big one is informed consent. Because the person's more than likely delusional, whether or not they can fully give informed consent is another issue. Having them write their own advance directives on what they want to happen to them. That may or may not be an ethical dilemma because you don't know who they are at that point. They may be completely different than they would have actually wanted to believe. So getting informed consent is a big issue in this. Also, supporting risky or ambitious behaviors. If someone wants to, go on a competitive career, it may not be the best fit for them because they're schizophrenic. However, their quality of life also needs to be taken into consideration. Just because they have schizophrenia does not mean they should not be able to live their life as they see fit. So telling them that they can't do this because it's too risky may be holding them back from actually getting something out of their lives. Another ethical consideration is persuading them to involve their family members. Because the family is tied to schizophrenia in so many ways in family history and dealing with schizophrenia on a daily basis, we really need to get the family in. So persuading them to involve their family may be a hard thing to do because it can be seen as coercion. You're coercing them to involve their family because they're under a delusional mindset, so they may or may not see that as coercion. And the last thing is prodromal schizophrenia. This is before they're actually diagnosed with schizophrenia, their family history, their genetics, and whatever is examined, and they're told whether or not their chance of getting schizophrenia. Telling someone this may or may not destroy their lives. So, telling them that they may get schizophrenia, that they have a high chance of it because their family history is ripe with schizophrenia, may not be the best idea, but it's on a case-by-case basis, as with all the ethical considerations. So just looking at it on a case-by-case basis would be helpful in determining whether or not to do it. Something we need to be careful about is that schizophrenia is culturally bound. In America, schizophrenia is delusions, hallucinations, talking to voices in your head, etc. That's considered abnormal. In other cultures, it may be deemed as a spiritual experience. So we need to be careful when we're dealing with those clients that we understand that their culture may say it's okay. Their family may not think it's a problem, but it is. And other cultures may not believe schizophrenia is even a thing. They may believe that schizophrenia is just something Americans came up with, that the Western globe came up with. So we need to be careful when we're dealing with that we're culturally sensitive to others, and that we make sure that we have all the information before making a diagnosis. Assessment tools used for schizophrenia are as follows. Recovery Assessment Scale has good construct validity, good content validity, good internal consistency, test-retest validity. However, its user-friendliness is very poor. Other scales using personal recovery with reasonable psychometric properties include the Self-Identified Stage of Recovery Scale, good construct and content validity, good internal consistency, but poor test-retest reliability. Good user-friendliness. The Mental Health Recovery Measure has good content validity, but poor construct validity, and good internal consistency and test-retest validity. Let's see, the good for instruments assessing comorbid depressive symptoms in people with schizophrenia. The Brief Psychiatric Rating Scale for depression, positive and negative symptoms, syndrome scale depression, Hamilton Rating Scale, Calgary Depression Scale for schizophrenia, and Beck Depression Inventory. These are all to gauge on whether or not the person has schizophrenia or another comorbid disorder, or if they may have just another disorder altogether. But the scale for depression showed a medium-sized correlation with some symptoms measured using various scales, suggesting poor divergent validity for these instruments. The best construct validity is a Calgary Depression Scale for schizophrenia and the Montgomery-Åsberg Depression Rating Scale. The highest ranges for sensitivity and specificity were reported for Calgary Depression Scale. And finally, there are good known groups validity for the short from Health Survey 36 and schizophrenia, but inconsistent convergent validity and poor responsiveness. Schizophrenia is a disturbance in the brain's functioning. It can seriously disturb the way people think, feel, and relate to others. About 1 person in 100 develops schizophrenia. Men and women are affected equally. However, men tend to have their first episode earlier than women. With women, the onset is usually a few years later. In the beginning, in most cases, it can start gradually and the person will start to have symptoms, but they and their families may not be aware that they have full-blown illness until it happens. There are 3 phases: prodromal, the beginning, active, and residual. The prodromal phase, people may begin to lose interest in their usual activities and withdrawal from friends and family members. They may become easily confused, have trouble concentrating, and feel listless and apathetic, preferring to spend most of their days alone. This is a big red flag. If their personality changes to that extent, to where they withdraw from everything when they were once outgoing and hung out with everyone, they need to be seen immediately. They may also become intensely preoccupied with religion or philosophy. That can feed into their delusions. This phase can last weeks or months. The next phase is the active phase. During schizophrenia's active phase, people may have delusions, hallucinations, marked distortions in thinking, and disturbances of behavior and feelings. This phase is often the most frightening for the person with schizophrenia and to others, because they may feel like they're going crazy. Because they're seeing things, hearing things. People are telling them that's not there. That can't be happening. Then the person begins to feel more and more self-conscious and may actually withdraw more. In the residual phase, after an active phase, people may have listless, have trouble concentrating, and be withdrawn. This phase are symptom and outlined under the prodromal phase. So pretty much if they've had an active phase already, the next phase would be the residual. So it wouldn't go back to prodromal, because prodromal means they haven't had a big active phase yet. So if they've already had an active phase, it goes to residual normally. And active phase can last a while, depending on every person, because it's a heterogeneous disease. So when dealing with a client, figure out what stage they're in. Are they in the prodromal, active, or residual? And the treatments available for each of those will help. If there's no response to treatment, or there's low adherence or persistent suicide risk, the use of clozapine is recommended. This is an antipsychotic. Initiate the administration of low-dose and general antipsychotics. This is if the person is going through their first psychotic episode. A 24 to 48 hour antipsychotic free observation period is recommended, but benzodiazepine may be able to help anxiety and sleep disorders. If there's a response to treatment, maintain treatment over a period of 12 months, and if there is a symptom remission, gradually reduce the dose over a few months with close follow-up. This is during the psychotic phase, which can last months. If there is no response to treatment, assess the causes. If it's poor adherence, analyze the reasons, optimize the doses, and provide help to get compliance. If there is response to treatment, switch to adherence, second-generation antipsychotic, and assess outcomes over a period of 6 to 8 weeks. If a second-generation antipsychotic are being used and there are side effects, switch to a first-generation drug should be considered. So it all depends on the person and what they're going through at the time. If they're going through an active psychotic phase and they're persistently suicidal, they'll need to be put on antipsychotics immediately and put under observation. Psychosocial intervention in the first psychotic episode. CBT is recommended for the prevention of psychosis, progression, and early intervention, reducing the prescription of drugs and symptomology. So once symptoms are under control, the person can undergo CBT to help with distorted thinking. Treatments and early intervention teams or multi-element programs are recommended in first psychotic episode. And the informative campaigns are recommended to help recognize prodromal symptoms in the general population. This is to help those who are undergoing the prodromal stage of schizophrenia, but they don't know it. They haven't had a full-blown psychotic episode, so they don't believe there's anything wrong with them yet. And making this education available to the public will help. Very accessible deduction teams are recommended for DUP and its compounding outcomes. Care should be provided in least restrictive and coercive settings as possible. So, helping the person through the least restrictive ways possible. If they need to be strapped down to a bed, they need to be strapped down to a bed. However, doing that just in the beginning is not a good idea. You need to build rapport with the person and help them trust you. Supportive family intervention is recommended. So this is why there's an ethical consideration between involving the family. Because family may not know how to deal with this, so they may not be the best support at this time. Intensive case management is important in this case because schizophrenia rarely is the same among everyone. So intensive case management to help that person manage their schizophrenia is important. And knowing what drugs they're on at the time and what's working and what's not is important in dealing with the first psychotic episode the person has. The recovery phase after the first psychotic episode is important in treating schizophrenia because some of the goals are to achieve realistic academic or employment objectives, to be able to help them in their reality and deal with their daily life after their first psychotic episode, to develop social relationships and normal sexual development because that can sometimes be stunted because of their illness, to provide support and to achieve an independent life so they won't have to rely on other people to constantly be there for them. So during their recovery stage after their first psychotic episode, they need to be given tools to deal with the aftermath. to promote the establishment of personal values and identity. A person may not know who they are anymore, and so they need to know, so they need to find out what they like, what their values are, and who they are. To provide adequate age-adjusted support to minimize the effects of the disorder in their life and empower him or her to cope with it successfully. So they need the tools to deal with daily life now, because now they have an illness, a chronic illness like this that will not be cured, or that cannot be cured at the time. They need to know different coping skills to deal with this, to limit their suffering and negative consequences of psychotic behavior. And so there's a lot of suffering going on there. The person doesn't know who they are anymore. They may, lose days at a time and not remember what happened. And this also to provide support for their families, because their families are an important role in a lot of people's lives for their support. To be sensitive to factors that may hinder adequate follow-up treatment, such as negative effects generated by assessment of procedures that cause rejection, side effects of medication, stigma, or other obstacles to a collaborative relationship. So we need to be sensitive to what they want and what they need. Everyone needs and wants something different, so we need to be aware of that. To offer treatment for associated problems such as suicidal tendencies, depression, aggression, substance use, cognitive impairments, anxiety disorders, instead of simply assuming that they are secondary phenomena. It's all interrelated. So we need to offer treatment for those problems as well, because otherwise they will continue to have those problems. Those problems are comorbid with schizophrenia. And to reinforce the concept of biological illness, to let them know this isn't your fault. It is biological. It is not in your head necessarily. To emphasize the need of drug and alcohol abstinence, because that can increase their psychotic episodes and delusions. To obtain the commitment of the patient and his or her family's cooperation process, they need to be aware that they're going to be taking medication for the rest of their lives, and that their family needs to be aware of this. And to provide continued support and treatment adherence, and provide comprehensive psychoeducation on their symptoms. So they need to know what symptoms to look out for, and what to do when that happens, what to cope with, how to cope with it. And it's also to facilitate opportunities to reduce social withdrawal by means of group-based treatment. So they may want to meet in a group so they feel like they're not alone in this. A lot of people feel like they're alone. They get paranoid. So we need to let them know that this happens to people. There are others like you. And it's also to help rebuild their self-esteem. They may take a big blow to self-esteem when they're told that they have schizophrenia or they've had their first psychotic episode. This is also to provide social skills training. They may not know how to socialize after that. And one of the treatments that we like to emphasize is CBT. Early implementation of CBT is supportive and helps their therapy helps their therapy work better and boosts a faster recovery. It reduces symptoms more than standard intervention, and it may have long-term 18 months to more benefits on these symptoms. CBT also offers better outcomes than standard interventions in suicidal risk, hospitalization, symptom reduction, adaptation of disease, and quality of life. So CBT helps them in a lot of different ways. When comparing CBT with supportive therapy and standard treatment, CBT offers protection for future relapses in the next 18 months. So CBT helps with relapses. CBT is also used in substance abuse. This is why, because it helps guard against relapse. Patients who receive CBT present fewer residual symptoms than those who don't. So the person may have fewer symptoms because of it, because they've learned how to deal with it on a cognitive basis. It may also prevent future hospitalizations and relapses and promotes better adherence to medication. It may help the person not become hospitalized because now they're adhering to their medication. They understand why they need to take the medication. They're not just taking it just to please the doctors. They're taking it because they know what it does. Family members and carers exercise a crucial role in access of care with their first psychotic episode. So the family members have to help with their adherence to medication. The continued use of medication will need adherence to it. So getting the family involved, involving the client with the family, making sure they're all on the same page with this. That there's not one family member who's like, oh, they don't need it. Or there's one who's like, oh, they only need it when they have their psychotic episodes. No, just because you feel better does not mean you should stop taking the medication. So letting the family know that they will more than likely be on medication for the rest of their life, they need to know that, because otherwise they may say, well, they're looking better, so they don't need to take it anymore. So these are important factors in treating schizophrenia. Thank you for watching the training video today in dealing with schizophrenia. There are obviously more stages that need to be covered eventually, but those are the main stages that are needed to be covered. And so in your working with schizophrenic patients, you need to be aware of all those things and the treatment for each stage and intervention, what you can and can't do, all the stages, even prodromal, understanding what prodromal is, and also in dealing with the first psychotic episode. The person may need medication. So, thank you for watching. This is Amber Pace, and have a good day.